All right, good afternoon. Thanks, Natalie. I'm going to talk to you about hemodialysis access and some of the measurements we do. Still have nothing to disclose. Just to review quickly, our goal is to detect abnormalities within the access that may lead to that access site thrombosing or having poor function during dialysis, or having difficulty cannulating for dialysis, or we may be evaluating patients who have symptoms in the arm, which I think Dr. Singh might cover next a little bit in more detail. But the goal for our ultrasound evaluation is to preserve each access for as long as possible. We're getting better at keeping folks alive longer, so these access sites need to be maintained. Surgeons, general surgeons, vascular surgeons can get very creative. There's a number of accesses that can be created. I think probably the most common is the old brachiosemino fistula, where the cephalic vein is anastomosed to the radial artery. We can also do a number of things up at the antecubital fossa. One of the I don't want to say last resorts, but a less favorable or less optimistic long-term patency would be to use a graft, a synthetic graft. Fistula first campaign in the United States obviously pushed away from the use of graft material to autogenous vein. This is one of the favorites that some of the surgeons in Albany use. They use a basilic vein transposition. But I think if we're scanning these things, if they're not our own patients, we've got to get the op note so we can spend the time scanning and not trying to sort out what's hooked to what. Also, briefly, terminology. Terminology can be confusing with these structures. You may, if you're not familiar with this, as you read the literature, you may see the artery that's feeding that fistula termed the feeding artery or the inflow artery. I tend to use inflow artery. Sometimes some people may call it the afferent artery. The vein that's now the source for the dialysis nurse to cannulate is termed the draining vein or outflow vein or efferent vein. Probably the harder thing, I think, is figuring out what do we call it in terms of proximal and distal, because that kind of gets confusing. I've seen some folks use cranial and caudal, or downstream or upstream. I think whatever you use should be documented in your protocols and defined so that somebody can kind of come to the same conclusions if they're picking up your work. Predominantly what we measure on ultrasound are two different things. We're either measuring velocity or we're measuring volume flow, and actually we're going to be doing both. In terms of velocity, we're going to take it over multiple sites, but with volume flow, we're usually going to pick a singular location and take our measurement there, and I'll discuss where best to take that. New to those of you who aren't in the ICA accredited lab, you may not know this, but starting next year, the IAC has added the requirement of taking a singular volume flow measurement somewhere, and we'll talk more about that in terms of where. But volume flow is done by many folks, and it was felt that it should be added. We all know when we measure velocity, we follow the standard rules, right? 60 degrees or less. Line our cursor to parallel to the wall or parallel to the color jet. I use to the wall. And if we suspect a stenosis in a fistula, we're going to do the same thing we do in any arterial circuit. We're going to get before that area of concern, get the highest velocity within the stenosis, and then distal as well. Volume flow is something many folks have not done. That was one of the first things I did, but up in Albany we were interested in a lot of flow rates through our in situ bypasses, so that's how I learned how to do volume flow. Basically, the flow through any tube is determined by multiplying the average velocity through that tube by the area, and we get our volume flow. What we'll want to do as operators is when we're measuring volume flow, if you can see right here, our sample volume is opened up quite wide. We want to make that as wide as the vessel. We'd like to pick an area where the conduit is fairly straight and of uniform diameter, and those of you who scan AV fistulas know that this is a challenge to find a good straight spot. We don't want to pick an area with lots of turbulence, and many folks will take a couple of measurements and do an average of those measurements. We want to come away a little bit from the anastomosis because as we ask blood to make a turn and go into any new tube, any new tributary, any new branch, we lose that laminar flow profile, and it takes several centimeters before we get a more parabolic flow profile with more laminar flow. And you can see that perhaps in these examples here. In this fistula, right at the anastomosis, we're getting a pretty broad spectrum here, a fair amount of turbulence. We're down maybe 4 to 5 centimeters from that anastomosis, and while there's still some turbulence, it is a lot more laminar there than it was more close to the, excuse me, to the anastomosis. Here's an example of a volume flow calculation, again, opened wide up, and we can see these vertical calipers placed here over 5 cardiac cycles, and we're taking an average of the velocity between those two markers. And in this instance, the volume flow comes out to 1.6 liters per minute, which is great. That is really fantastic. What we need to document images, of course. We're not all about Doppler. We're going to take some color or grayscale images of the inflow artery, anastomosis, the outflow vein, any areas where we suspect a problem, and velocities at those same levels. Now, I mentioned volume flow briefly. Most of us have had the experience of measuring volume flow within the outflow vein itself, again, a few centimeters away from the anastomosis. There's a good body of literature that says that perhaps we should be measuring volume flow in the inflow artery, just above the anastomosis. There's a big multi-center trial that's about to be published very soon, which will hopefully delineate a little more information on volume flow. So right now, I actually do it in both places just to see what I get. In terms of images, which I'm not focusing on imaging information in this talk, but we can see all the lumps and bumps and bruises and hematomas. Obviously, those should be documented. But what we want to do with our ultrasound is to find when can we use that AV fistula? Is it mature? Is there a stenosis? And most importantly, is it going to stay working? So we look for interpretive data. The absolute velocities vary. Some folks will expect up to 300 centimeters per second. I routinely see much more than that in many of our fistulas, but there'll be a lot of turbulence. And that outflow vein, efferent vein, will also have high velocities. We don't want to see low velocities either, particularly in a prosthetic graft, because that could put that graft at risk for failure. Generally speaking, we want the velocities above 150. Obviously, to document graft occlusion, we'll see material within the graft itself. We'll see the absence of color and Doppler. And the big tell for graft occlusion certainly is to look at the inflow artery. This brachial artery is feeding a very nice, healthy patent AV fistula. This is a very normal brachial artery that would be found in URI, hopefully. As we walk through the whole circuit, again, we'll go from relatively laminar flow in the inflow artery, seeing some turbulence across the anastomosis, and then slightly lower velocities in the outflow vein. Criteria. Well, it does vary a little, but generally speaking, people will use a 3-to-1 ratio using a velocity about 2 centimeters upstream in that artery to compare for stenosis. So a 3-to-1 ratio is indicating at least a 50% stenosis. Some people will use 400 centimeters per second. The important thing is make sure you see something. Make sure you can appreciate a defect either on grayscale or grayscale in color. Because of the angulation there, you will see some turbulent velocities across the anastomosis that will impact our findings. In the vein itself, the fistula, once that vein's arterialized, we can use the standard 2-to-1 ratio for a 50% stenosis. That holds pretty well. A 3-to-1 ratio, some folks use to indicate a greater than 75% stenosis. If we do see a stenosis, we can see in this image here, the vein's fairly fat and narrows down over here, and our velocities go pretty high, about 600. And here's a close-up of the vein where you can see the tapering. It may be helpful for the physicians you're working with to mark where that stenotic area is and measure the distance if it's close to the anastomosis. Sometimes there's enough redundancy in the vein that they can do a primary procedure to fix this. Other times it may require something more extensive. Well, we talked about criteria for velocities, but what about volume flow? I said we need to measure it. We should do it at least at one level. Generally speaking, below 500 is bad. Above 800 is great. Somewhere in the middle is something to watch out. In synthetic grafts, PTFE grafts, we want very high flow rates, again, to keep it above that thrombogenic threshold. We look for at least 800 in those. The flow changes we observe on ultrasound, interestingly enough, if we were to look at pre-op flow values in radial or brachial arteries, they're pretty low, 25 and 50 respectively. Immediate post-creation of that fistula, within about a day, most grafts will reach about 40 to 60% of their maximum flow rates, which honestly, that's not something I knew before. I found that out researching this for this talk. We can really increase the baseline flow 10 to 20-fold, but within about a day, we're almost halfway there. And generally, in about a month, we're pushing about as much flow through there as we'll get. Now, volume flow, velocity. Can we use one or another? Are they telling us the same thing? No. They're telling us different things. They are complementary pieces of information. The velocity data is going to tell us not about long-term performance, but whether or not we've got a stenosis, and it's going to clue us into that stenosis, and the velocity data we can use to track an individual patient. The volume flow data is going to tell us about long-term performance. It won't tell us we have a stenosis, but if we have low volume flow, it's going to signal us to kind of take a look in more detail and that maybe we missed a stenosis that's there. This is an interesting paper that looked at long-term outcome, and it said that if your volume flow in your fistula is less than 500 mils per minute and the diameter is less than 4, you have about a 1 out of 3 chance of that being maintained long-term. But if you have a high flow rate above 500, a good sized vein above 4, that has a 95% chance of maturing and satisfactorily performing. So one other thing, it was mentioned earlier, the rule of sixes. Some people use this. 6 weeks post-op, we need a 6 millimeter vein. We need it less than, 6 millimeter or 6 centimeters, 6 millimeters from the surface, and 600 mils per minute volume flow. The pitfalls with doing this, the flow rates are turbulent, the angle correction is challenging. You do need to follow the entire course, but they're so superficial it does present a challenge. Measuring volume flow is also difficult, and those of you in my workshop, we went through that a little bit, but find a straight segment with a uniform diameter, that will help. Peak systolic velocity is what's going to be reflected by some of those pitfalls or impacted by some of those pitfalls, and certainly our flow rates are going to be determined by where and how we measure and what segment of vessel. So we've got to use both. Use the velocity to confirm a local abnormality and volume flow to confirm overall function. Thank you very much.